high level, we won't get into all the details, but high level changes that the West Virginia State Legislature put into place at their 60-day session that ended in March that impact either our patients or our programs. So the first, you can go on to the next one. The first bill that I just want to hit one clause that was passed. There was a huge foster care bill this session that was passed. It's basically handing over the foster care system to managed care organization. And obviously foster care, our patients are impacted by the foster care system, but in particular, this new clause in red here was added to this bill, which apparently around the state, some courts were taking away children because their parents are on Suboxone, and that was the only reason. And they were adherent to treatment and doing everything right. But the legislature did do a very noble thing and is telling the courts that that cannot be the sole reason that a child is removed from the home. So the patient would have to show that they're complying with the treatment obligations of the program. So some of you may be asked to, in the future, write a letter saying such for them to take to the court. But this is a good change, in my opinion, and it certainly is a motivator for a lot of people in recovery to keep their children. So I was very glad to see this. Go on to the next one. Another bill, this is another really good bill, and I think Dr. Berry and his group with the governor's task force or the Office of Drug Control Policy, one of you two groups had recommended this to the legislature. But this is, it's going to go into effect this summer in June, and it exempts very small programs that are serving 30 or less patients. This is usually like a primary care clinic or some other service line that wants to integrate treatment with MAT into their programs. Those clinics would be exempt from the huge responsibilities of registration and following the rules of OFLAC. So they will still have to attest that they're doing a few things, like they still have to require counseling, they still have to require drug screens and a diversion plan. And of course, the people that prescribe MAT will have to have completed the waiver training. But besides that, other than they may have to provide patient numbers and then the caveat of any other information required as asked. But all the registration requirements and all of the rules that are related to the 16.5Y section, they won't have to comply to. And this also applies to licensed behavioral health centers. So they will no longer have to do all the reporting to OFLAC and adhere to all the other rules. So this may not apply to some of you, or it may, I doubt it, but as you expand or share with your colleagues in your communities or your neighboring counties, that if they are interested in treating, these caveats are now available. That really reduces a lot of burden for people that are interested in taking care of this patient population. This bill, it was actually vetoed, but it is going to come back in the special session. So we anticipate this bill will pass by July. But if you recall, the state code is very prescriptive of who can provide counseling and medication office-based MAT programs. And so up there is listed exactly who can. Licensed psychiatrists can't be just any physician. It has to be a psychiatrist physician. Alcohol and drug counselors, master's prepared counselors, psychologists, social workers, family therapists, if they have training in addiction, bachelor's prepared social workers, if they're supervised by an alcohol and drug counselor. But what this bill did was add psych mental health NPs and psychiatry certified physician's assistant to this list, like Sarah, she's a psych mental health NP, while she's prescribing now, technically, by the code currently, she can't provide the counseling in that same clinic. So this bill was introduced to help out because mental health providers, the counseling is going to be the biggest barrier to more programs. I mean, I think more and more people are getting waived to prescribe, but if you want to provide wraparound services, really help these patients, that's going to be our barrier. So hopefully that will get taken care of this summer, and we'll continue to try to get more qualified counselors to be able to provide care in these centers. Next one. I do want to remind everybody that even though the code is very restrictive and the rules are very voluminous, there is a method to get waivers or variances from OFLAC. For example, if you can't find one of those listed counselors that meets the law's requirements, you can, and you find somebody else that you believe is qualified, you can request OFLAC to give you that waiver. And there are other things that if you're a nurse practitioner, you can't find a physician medical director, particularly if you're in a community that's very small and there's no treatment, you can ask OFLAC if you can run a clinic, a small clinic yourself with your other patients, like primary care patients, for example. So that there is, and I don't know if anybody's ever talked to JoLynn Mara, but she's the executive director of OFLAC. And I talked to her for over an hour about this, and she was just giving me examples of things that anybody could request waivers from. And they really seem to have the attitude now of trying to expand treatment themselves. And so, yeah, they're really open to this. So if you find yourself or colleagues running into this, this is an option. That's been my experience too, Tony. She's been very helpful. And in every conversation, every meeting I've been with the state, they want to do what they can to create more access and make it less burdensome. So that is certainly the spirit by at least the people who are working within the state. So next, we're going to go just quickly through some of the rules changes that West Virginia has a very unique process for agency regulations, and that our legislature does take part in approving them. A lot of states can write rules in the agencies, and then they have to be followed. But our legislature likes to get their hands in and approve any rules that agencies submit. So in May of last year, the agency OFLAC put out the rules that they wanted to get passed. There was a lot of amendments, and I know Dr. Berry wrote a letter and shared it with a lot of people giving public comment. And so a lot of you on the call and that are in the expansion grant wrote, and OFLAC did modify the rules, and then it went to the legislature for a rulemaking committee. And then it went to the full legislature. So there were other opportunities to get changes made. So we're going to go over just some of these. So next slide. So one of the comments that a lot of people had submitted was, let's get rid of these quarterly statistical reports. They're a big burden. And everybody said, no, we're not going to get rid of them. In fact, we're going to make you do more stuff. So the quarterly statistic reports are still in play. Unless, of course, you have less than 30 patients and you're treating under that other bill that we talked about, 3231. But if you have to follow the rules, you're now going to have to also give the breakdown of gender. And some people might have already been doing this, but now it's going to be mandated. The number of, did we do that? I wouldn't think that people were doing, and this doesn't go into effect. The number of patients admitted during the quarter. So you have your total number of patients, and then you have to put how many were specifically admitted during that particular quarter and the number of pregnant patients. And this isn't these reports. This is just generally a new provision of the rules that patients have the right to choose a counselor who accepts their insurance. So I think in a lot of clinics, everybody, the prescriber and the counselor, therapist, are credentialed through the same payor, the third-party payer. But apparently there's been some instances where a patient gets their prescription from the prescriber, but then the counselor they refer them to does not take their insurance. So they're forced to get a bill and they can't afford it. And so this was a way that they thought it would help patients. Patients have to be informed if their therapist takes their insurance, and if they don't, they should be referred to a new counselor who does.
As if that's an easy thing to do.
It's not nearly as easy as it sounds. Another comment made during the public comment period was about currently in the rules, if you have a pregnant or if a female patient is going to be administratively withdrawing, that you have to test them to make sure they're not pregnant, because they have preferential treatment under the law if they are. And the comments were, well, a lot of these people are administratively withdrawn because they're not coming. So we can't test them if they're not coming. So they put in a caveat now that they still want us to do that. If a female patient is going to be discharged, that they want us to test for pregnancy. But if they're not showing up, or if they refuse, that's fine now, but just document that fact. And the same thing with referring a pregnant woman that's discharged from clinic. You're supposed to try to get a referral to another place, but if you can't, just document that you tried and you were unable. And the third bullet on this is a good one, because a lot of people commented that the FDA approval for Suboxone is 16, not 18. Previously, you could only prescribe it at 18 or older in office-based MAT programs, but they did lower that now. So 16 is approved and appropriate per OBMAT. Next. This was the one amendment that the actual legislature made. So it had gone through OFLAC, it was approved through interim rules, it went in front of the House of Delegates, and they made an amendment. Now all of our programs have to provide or refer each patient to obtain contraceptives, devices, or procedure. Now, so obviously you can't make a patient take contraceptive drugs, but you have to either your clinic or refer them somewhere to address reproductive health.
Is that for males and females?
It says specifically each patient. They also amended the provisions for the random drug screens. Previously, the rules said that you need to do a random drug screen once per quarter minimally. Of course, Medicaid policy was different and required more. This aligns a little bit better with Medicaid policy, but not exactly. So the new rules are for the first year in treatment, you have to do 2 randoms per month. From 1 to 3 years, a random per quarter. And then after 3 years, at least once a year, but more per the provider's discretion. This is a little different than Medicaid's. The first year is the same as Medicaid, 2 per month for the first year. But then phase 2 in the Medicaid manual requires 1 per month. So even though the law is saying 1 per quarter, Medicaid says they want you to do 1 per month. A lot of things were removed, which is good. There was a big section about initial assessments and what you had to do for an initial assessment before you admitted a patient into your program. That whole entire section, that definition was removed. Again, to remove barriers of getting patients into an actual program. Also, there was really prescriptive educational requirements for non-physicians and therapists. They were requiring 20 hours of training on really specific things. They reduced that 20 down to 12. And if that individual has worked in an addiction before, it can just be 6 hours of training. And they're no longer as prescriptive about what training you have to provide. You don't have to train everybody on opioid treatment and detox protocols and toxicology screenings. And it's just that they have to have some training about the model. And again, 12 hours instead of 20. They also removed the requirement to provide 24-hour, 7 days a week procedures to allow other healthcare providers that may see your patients access to the prescription and dose information. Obviously, we still collaborate, and there's still a requirement that if a patient's in an emergency room, that the ER physician has a method of paging someone if they need to get any input on that particular patient. And they also removed language relating to security personnel. Previously, the rules required you had to have personnel in the lobby and in a parking lot, and if you had contracted security, you had to train them, and HIPAA. They took all of that out. They also took out the detailed job descriptions for staff and volunteers, and that you would have to go over that with them initially when they interviewed, when you hired them, and if their job changed. And they used to have a requirement for orientation within 10 days. They no longer have that either. So they really are lifting a lot of the mandated, this is how you're going to do your job language. Next. They've removed the requirement for vocational and education services referral. They removed the requirement for instruction on maternal, physical, and dietary care and on-site parenting education for parents and pregnant women. And they removed the requirement to report overdose deaths. Before, if you were aware of an overdose death of one of your patients, you had 24 hours to report it. They removed that requirement. However, they still want us to report suicide or suicide attempts. And I do want to make a comment that a lot of these things that were removed, some people made a public statement saying that these were good things. Why are you removing them? Just because this has been removed from government language doesn't say that you can't do it. It just says you don't have to do it this way. Next. No longer do you have to have available same-sex groups or same-sex counselors. Previously, that was required to have availability of. Therapists don't have to close their charts in 3 days. And if a patient relapses, there previously was a requirement that additional counseling had to be provided. That's been removed. And just in general, all the things, the post-assessment, admission assessments and other things, the language has been removed to shall, meaning you will do it, to may, meaning you can do it. We would recommend that you think about it, but it's not an absolute requirement. And there also is a plan of care plan, as we typically call it. But previously, you had to update that quarterly, document it quarterly. The patient had to acknowledge the plan of care, and again, that language on care plans or plan of care has changed from you shall do this big list of things to you may do this big list of things. They took out the estimated length of treatment. Previously, they wanted us to guess how long a patient would require treatment in office-based MAT. That is an impossible estimation. So they took that out of the coordination of care agreement. They took, again, the big list of prescriptive requirements they used to have, what should be in the coordination of care agreement, away. They took out the entire section on detoxification programs. Again, detox programs are still available. You can still send your patients, but before you really had to address referrals to short-term or long-term detoxification programs. And you no longer have to provide a written copy of your clinic's withdrawal policies and procedures. Certainly, you need to inform your patient, but I'm sure that everybody does anyway. Before you had to provide them that in writing. You don't have to do that anymore. Okay. So this is a link for the final rule. Once they integrate everything, all the changes that were made after the comment changes and the legislature changed it, they'll integrate it onto the Secretary of State site. And this link will take you to the Secretary of State site. If you go to the next screen.
Oh, I'm so sorry.
This is what it will look like when you hit that link. And the top red arrow where it says legislative in progress, when they have put the whole rules bundle together, that will say legislative, and in green it will say active. And that lower arrow pointing to the left, instead of modified file, it will say in bold final file. So then you can click on that and you can read the whole big rules bundle and note all the changes that are made. All in all, if they didn't take out everything that was recommended from people actually practicing in this realm, but they did take a lot into consideration and change quite a few things. So it is a much shorter, the regulations are much shorter than they used to be. Any questions?
That was awesome. Thank you, Tony.
Thank you.
Yeah. All right, guys. Yes, Camden Ongali is waving. Hello.
Hi, I have a question about the quarterly report that we had to send in. What quarter is that? Is that the state quarter, or when do we send those in?
So quarterly reporting is every 3 months. So there's actually a quarter report due by the 15th of this month.
August 15th?
No.
April 15th.
April 15th.
Okay. I didn't know if we were all on the same quarter, or if it was according to when we started, or what.
Nope, it's all the same quarter.
Okay.
It should be January, February, March, April,
Okay.
May, June, July, August, September, October, November, December.
Okay. Thank you.
Okay. Does anybody else have any other questions? You all are on mute. I'm happy to unmute.
Just a request. Can you guys send us these regulations by email?
Yeah, absolutely. I'm going to be sending out the
That would be awesome.
Yeah, no problem. We'll be
Yeah,
sending out the slides from Tony with the links and everything, so I can send that along as well.
Okay, great. Thank you.
I was just going to say that the wonderful improvement in lifting the restrictiveness of the kind of the expectations of the government on MAT. So it's nice to see the change.
There's been a big change in attitude down there too. I have to say, in 2016, when they statutorily defined office-based MAT programs, they were very, and not that they're not concerned now, but they were very concerned about creating another problem with treatment. And I think through a lot of work of you, I know Dr. Berry has presented to several committees down there and stakeholders. They really are starting to see the appropriateness and the importance of treatment.
Yeah, I'll echo that. That it has also been encouraging just to see the level of acceptance and some reasonableness that wasn't there before. And I think it just goes to, for everyone out there who's doing this, if you could, do what you can to just share the stories of your patients with who will ever listen. And when you have opportunities to go to speak before legislators or town halls or probation officers or whoever it is, please take advantage of doing that, because I think it really does make a difference the more you do that over time, because I do see change happening.
Dr. Bo, are you trying to speak? I don't see that you have your mic on.
Your lips are moving, Dr. Bo, but no voice is coming.
Let's see. Do you have your mic? Maybe there's like a mute button that looks like a speaker in the left bottom corner. Check and see if that's on the right mic with that little arrow next to it. Oh, I'm sorry. Dr. Bo, you can chat it to us as well.
You do the chat function.
Yeah.
Okay, I think it's working now.
Oh, hey, hi.
Okay. In terms of male contraception, do we get funding to provide condoms and for female the oral contraception if they want it?
Do we get funding?
Yeah.
Because,
you know how the program says we should offer these things or refer?
right.
Right. So if the lady does not want to go to OBGYN, does the program then, because sometimes people they can't afford OCPs.
Mm-hmm.
Yeah. If they want them, and condoms are very expensive. So I wasn't too sure,
Well, I mean, strictly there's no extra funding in here from DHHR or any other organization that was given to clinics to provide that. Obviously, if they're Medicaid covered, then that would cover a woman's oral contraceptive, but condoms aren't covered.
Wow. Okay. Thanks.
Hi, this is Kendra. I have a question.
Okay.
Can you guys hear me?
Yes.
Okay, sorry. Tony, I know I have talked to you a little bit about this, and I'm sorry, but my internet cut out when you were talking about the issue of medical director. I think you may have covered some of this language in the code where nurse practitioners or nurse managed clinics may have trouble starting office-based MAT because of the language, the way it's written, with requiring like a medical director and a program administrator and so on that are physicians who are waivered. Could you just speak to that, because I missed that, and maybe a little bit more information? As you know, I am at HealthRight and we're contemplating doing some office-based MAT, but our program director is a physician who is not waivered, and I'm just not sure exactly the route we need to go.
Well, if you wanted to pursue a waiver or a variance, what I would recommend first is to talk to Jolyn Mara at OFLAC. But there basically is an application or